Welcome to the Insight Engine. Today, we are analyzing the exact immune mechanisms and immunofluorescent signatures of highly tested nephretic syndromes. The pathophysiology of Goodpasture syndrome is driven by a type 2 hypersensitivity reaction. Circulating IgG autoantibodies physically lock on to a highly specific target, the alpha-3 chain of type 4 collagen. This specific collagen structure exists in only two places in the human body, the alveolar basement membrane and the glomerular basement membrane. Because the antibodies target this exact structure, the resulting destruction hits both organ systems simultaneously. Clinically, this manifests as a bimodal crisis. Patients present with rapid onset pulmonary hemorrhage, coughing up blood, paired with acute renal failure due to rapidly progressive glomerulonephritis. When we examine a renal biopsy under immunofluorescence, this exact mechanism leaves a mandatory microscopic footprint. Because the collagen targets are distributed evenly across the membrane, the IgG deposits form a smooth, continuous, linear pattern. While corticosteroids and immunosuppressants are initiated, the immediate emergent priority is plasmapheresis. We must physically filter the blood and extract the pathogenic circulating IgG to halt tissue destruction. Because these antibodies are fixed directly to tissue antigens rather than floating freely, they create immediate, localized destruction. Traditional immunosuppression can stop future antibody production, but it cannot address the molecules already bound to the membrane. Only plasmapheresis physically clears the existing pathogenic load before the glomerular basement membrane is irreversibly scarred. This data table compares Goodpasture against its closest clinical mimic. Identical macroscopic presentations require strict mechanistic differentiation. Both Goodpasture and granulomatosis with polyangiitis, or GPA, present with the exact same severe hemoptysis and acute renal failure. We isolate GPA by examining its unique systemic footprint. GPA attacks the upper respiratory tract, causing purulent sinusitis and saddle nose deformities. On a renal biopsy, the glomerulus is pouchy immune, meaning it lacks antibody deposits entirely, while serum testing reveals high C-ANCA or PR3 positivity. Contrast this with Goodpasture. It completely spares the upper airway. Instead of a blank glomerulus, it presents with that strict, brightly glowing linear IgG signature. Let's test this integration. A 24-year-old male with no prior upper airway symptoms presents with severe hemoptysis, a creatinine of 4.2 milligrams per deciliter, and dysmorphic red blood cells in his urine. Which finding definitively isolates the diagnosis? Granular deposition points to post-infectious etiologies. Pouchy immune staining indicates GPA. Mesangial IgA suggests IgA nephropathy. The only correct answer is linear deposition of IgG along the basement membrane. A pulmonary renal presentation is diagnostically useless on its own. You must rely on the immunofluorescent signature and the upper airway status to confirm the exact autoimmune mechanism. We shift now to the type 3 hypersensitivity mechanism. Post-streptococcal glomerulonephritis is driven by circulating pre-formed antigen-antibody complexes that form following a group A streptococcus infection. These dense clusters travel through the blood and lodge within the subepithelial space of the glomerulus. Because these large complexes take time to form and lodge, diagnosis requires strict chronological latency markers. Renal symptoms emerge 1 to 3 weeks following an episode of streptococcal pharyngitis, or 3 to 6 weeks after an episode of streptococcal impetigo. Once deposited, the complexes trigger intense inflammation, producing the classic clinical triad of PSGN, gross hematuria resulting in cola-colored urine, acute rapid-onset hypertension, and severe periorbital edema. This bar chart highlights the systemic impact of the inflammatory response.
The massive volume of circulating complexes triggers an exhaustive consumption of the alternative complement pathway. This results in a profound drop in serum C3 levels, while C4, associated with the classical pathway, remains largely unaffected. Under the microscope, type 3 deposition creates a distinct signature. Immunofluorescence reveals a granular, lumpy-bumpy pattern of scattered dots, and electron microscopy shows pathognomonic subepithelial humps where the complexes have wedged themselves. The physical size of preformed immune complexes dictates everything about PSGN. It explains their delayed arrival, their massive complement consumption, and their lumpy granular deposition, completely separating them from type 2 linear attacks. This data table highlights our second clinical variance, comparing PSGN against IgA nephropathy. Both of these diseases cause post-infectious macroscopic hematuria in pediatric and young adult patients. We isolate the variance through latency and complement data. IgA nephropathy occurs concurrently, typically within 5 days of a respiratory or GI infection, and features normal complement levels. PSGN occurs weeks later, accompanied by a severely depressed C3. Let's test this. A 10-year-old presents with facial edema, dark urine, and hypertension exactly 3 weeks after an episode of impetigo. What is the most appropriate next step in diagnosis? A renal biopsy is overly invasive for a classic presentation. Anti-GBM testing targets good pasture, and ANCA serology screens for vasculitis. Given the specific 3-week latency following impetigo, checking serum C3 and C4 levels is the definitive next step. Macroscopic clinical mimics are not resolved by analyzing physical symptoms. They require strict adherence to chronological latency periods and complement biomarkers. We conclude with membranoproliferative glomerulonephritis, or MPGN. This pathology involves severe structural damage. Rapid multiplication of mesangial cells pushes directly into the basement membrane space, forcing it to split. On light microscopy, this creates the pathognomonic tram track or double contour appearance. This structural splitting is frequently initiated by chronic viral states. Pathologically, the most significant driver is chronic hepatitis C, which serves as the primary engine for the immune complex production seen in type 1 disease. Hepatitis C drives the production of mixed cryoglobulinemia. The body produces aberrant IgM antibodies that mistakenly target the Fc tails of its own standard IgG molecules, forming dense, cold precipitable complexes. These massive complexes deposit systemically. In the kidneys, they trigger MPGN accompanied by low complement levels. In the dermal vessels, they cause palpable purpura. Chronic viral infections alter immune complex production, creating multi-organ deposition syndromes. This requires you to trace the cascade back to the initial viral origin. This final data table highlights the variance between MPGN and membranous nephropathy. Both pathologies are triggered by chronic viral hepatitis, frequently confusing the initial clinical picture. You must separate them by their specific viral and structural markers. Membranous nephropathy is associated with hepatitis B, solid tumors, positive PLA2R antibodies, and a pure nephrotic syndrome. On electron microscopy, it forms a spike and dome contour. MPGN is driven by hepatitis C, cryoglobulins, a mixed nephritic-nephrotic presentation, and tram track splitting. This synthesis matrix consolidates the rules we have covered, matching the disease targets with their exact immunofluorescence patterns and key markers. Accurate diagnosis depends on the integration of temporal latency, complement data, and immunofluorescence signatures. Relying on macroscopic symptoms alone will actively mislead the clinical assessment.